Good morning, and thank you for joining this early session. First, I would like to thank the organizing committee for giving focus on young oncologists. I am still, for some years, a young oncologist from the Department of Oncology at Odense University Hospital in Denmark. In the next 15 minutes, I will discuss the impact on our clinical practice after the drug approval of new targeted agents in metastatic colorectal cancer, with the point of view from a young oncologist. When I had my first appointment as a medical student, it was just before the golden era of the colorectal cancer started. At that time, we only had 5 FU for the treatment of patients with colorectal cancer. However, this changed in the late 90s when the golden era started, first with the introduction of oxaliplatin and irinotecan, and later on with the introduction of the targeted agents. Later, we discovered the importance of the KRAS mutations for the efficacy of the anti-EGFR therapies. Furthermore, we realized that some of our patients might have a chance of cure with the resection of metastases. All these advancements made a shift in our view on the metastatic colorectal cancer patients. The metastatic colorectal cancer patient is just not one patient. We have now to consider if the patient have a chance of cure, and this is based on the resectability of the metastases. However, still, most of our patients are never resectable and thereby non-curable. And there the treatment aim is palliative, aiming to prolong survival and maintain quality of life. In this talk, I will focus on the group that are non-curable. So, which targeted agents are available in the treatment of metastatic colorectal cancer? These agents can be divided into 2 main classes, namely the anti-EGFR antibodies with panitumumab and cetuximab, and the anti-angiogenetic drugs with bevacizumab, aflibercept, and regorafenib, and with regorafenib just being approved by the EMA just a few days ago. This means that we now have many regimens and we have many combinations available for the treatment of colorectal cancer patients. And this, of course, raises several questions. Which agents to use, when to use it, and how to use them. And due to the time, I have chosen just to address just a few of these questions. And as I said previously, I would stick to the group of patients with non-curable disease. So, what are our options in the first-line setting? We know that both cetuximab and panitumumab and bevacizumab are efficacious in the first-line setting. And we know that the efficacy of anti-EGFR antibodies are restricted to patients with KRAS wild-type tumors, whereas bevacizumab is active in both KRAS mutant and KRAS wild-type tumors. So when all agents are active, which agent do we then have to start with? Several studies have been addressing this, and at the ASCO meeting just a few weeks ago, we had the first results of one of these studies. It was the FIRE3 study conducted by Dr. Heinemann, in which nearly 600 patients with previous untreated KRAS wild-type metastatic colorectal cancer were randomized to either FOLFIRI plus cetuximab or FOLFIRI plus bevacizumab. The primary endpoint in this study was response. And the results were that there were no significant differences in response rate in the intention to treat population. However, in the population of accessible patients, the response rates were significantly higher in the group of patients treated with cetuximab. There were no differences in PFS, which was about 10 months in both arms. However, and maybe a bit surprisingly, there was a significant difference in which median survival was increased with 3.7 months in patients treated with cetuximab. And I think it's a minor paradox that we for many years have been discussing why we only have improvement in PFS, and this improvement in PFS was not translated into survival. And now we have to discuss the opposite, namely why was there an improvement in survival but not in PFS. So there may be several explanations for this. Well, we know that it is not a matter of duration of the triple therapy, because the treatment duration was the same in both arms. Maybe there could have been a difference, an imbalance of the BRAF mutations between the arms, which we know that the BRAF mutations are associated with a poor prognosis. Or maybe the gain in survival is not caused by the first-line treatment, but instead are caused by the second-line treatments. Furthermore, recent data indicate that the deepness of response matters, as that the effect on survival on the size of tumor sprinkles is more pronounced than on PFS. So we still have several questions, and some of them may be answered later this meeting, where we will have the updated results from the FIRE3 study, and then we will of course have to await the results from the other ongoing studies before any final conclusions. So another question in the first-line setting in patients with non-curable disease is for how long to treat patients. Historically, we treated all patients until progression simply because we did not have any other options. However, from our daily clinical experience, we know that many patients need a treatment break or need periods with less intensive therapy. And with the approval of the new targeted agents, we have the possibility to treat patients with a less toxic agent, and therefore we now can consider different treatment strategies with intermittent treatment, which includes the stop-and-go strategy, maintenance therapy, or total breaks. This slide summarizes the randomized studies comparing maintenance therapy with total treatment breaks. In the OPTIMOX-2 study, 5-FU and leucovorin was used as maintenance therapy. In the COIN-B study, it was cetuximab, and in the recent studies, which were both presented at the ASCO meeting, in the SAC study, bevacizumab was used as single agent, and in the Dutch CAIRO3 study, the combinations of bevacizumab and capecitabine was used as maintenance therapy. All these studies are in favor of maintenance therapy with improvements in progression-free survival up to 4.4 months in the CAIRO study. So based on these studies, it seems that maintenance therapy is superior to complete treatment breaks. However, when interpreting these results, we have to be aware of the length of the induction period, because this was in the studies in the range from 3 months to 4.5 months. Do all our patients need maintenance therapy? Well, based on the result from the COIN trial and the OPTIMOX trials, it seems as we can identify groups of patients that can safely tolerate treatment breaks. In the COIN study, patients with normal platelet count at baseline did not benefit from continuous therapy. And in the OPTIMOX trials, it was found that patients that had a normal CA after 3 months of therapy and patients treated for 6 months could safely have treatment breaks. So, to conclude on maintenance therapy is superior to complete breaks if the induction period is less than 4.5 months. Furthermore, it seems as bevacizumab and capecitabine seems to give the largest benefit. However, we don't know, as none of the studies has been addressing it, that we could obtain the same results with capecitabine alone. And still, we know that some of our patients can safely tolerate treatment breaks, and this includes patients with normal platelet count at baseline, patients with normal CA after 3 months of therapy, and in patients with an induction period of at least 6 months. So, for the last minutes, I just want to have a few slides on later lines of therapy. So what are our options in the late lines? Based on the recent years' results from the large randomized studies, we know that anti-EGFR agents are active in the KRAS wild-type patients in the second and in the third-line setting. We know that the anti-angiogenetic drugs are as well active through all lines, with bevacizumab in the second-line setting, both in patients not previously treated with bevacizumab and in patients treated with bevacizumab beyond progression. This was based on the TML study and the BIOP study. And we as well know that aflibercept is also active in the second line, and furthermore, regorafenib is active in the third and the fourth line setting. The benefit in all these studies is an improvement in PFS up to approximately 2 months. So what seems to be important in order to improve survival is that our patients are exposed for all active treatment agents during the treatment period. And this was first demonstrated in the Tonegang study, which was the first study where there was a fixed treatment plan including all active agents. And in this study, we, for the first time, median overall survival exceeded 20 months. And Grothes demonstrated the same, where he showed that the survival of patients in randomized study were clearly correlated to the percentage of patients receiving all active drugs. So it is important to introduce all available drugs in the treatment of our patients. So to conclude, the approval of the targeted agents have had a major impact on our daily clinical practice. We now need to have a personalized treatment strategy, and it is not just a personalized strategy according to tumor markers, but it is as well including other parameters, as we have to decide the goal of therapy determined in a multidisciplinary setting. We, of course, have to take into account the KRAS status, and in the near future, probably some more of the downstream signaling pathways. And, of course, in the daily clinic, we have to consider patients-related factors as comorbidities and the patient's expectations. And as a young oncologist, I have to admit that I think that the treatment of patients with metastatic colorectal cancer is difficult and complex. Thank you.